can go.
Okay. So the next section that we're going to be covering is dermatologic terminology related to wound care. And we're also going to talk about some general issues related to wound care, classification, and to wound care management. So looking at terminology, when you're describing wounds or when you're describing skin lesions, you want to use terminology that's as accurate as possible and that's clinically recognized. So this gets into the field of dermatology. Now you'll notice that on your handout, you have grouping. So macule and patch are grouped together. Papule and plaque are grouped together. Vesicle and bulla are grouped together, as is pustule and abscess, because all of those are related terms. Now, macule and patch are exactly the same thing. The only difference is the size. And what you want to think of when you think of macule and patch is a flat area of the skin. There's no skin elevation, but there's a change in skin color. A freckle is a macule. A birthmark is a good example of a patch. So I sometimes think of macules and patches as spots, little spots and big spots. But if you ran your hand, your gloved hand over the area, you would feel nothing because there's no elevation. So it's just a flat change in skin color. And you see that here. Now if you look at the slide on top, one of the clinical situations in which we frequently use the term macule and patch is in describing a yeast rash, candidiasis. Very commonly what you have is a central area where the patch is solid. It may be flat or it may be elevated. And then you have distinct satellite lesions, and usually there's a mix. Some of those lesions have elevation, but many of them are flat. So we frequently refer to a yeast rash as a maculopapular rash with central patch formation. Or if there's elevation, we'll say central plaque formation. In this case, there was no elevation, so we would say this is a maculopapular rash with central patch formation. So now come to papule and plaque. Papule and plaque represent elevated lesions. So they're bumps. So macule and patch, spots, small spots, big spots. Papule and plaque, bumps. Small bumps, large bumps. Large raised areas, small raised areas in the skin. So again, 1 centimeter being the dividing line. If you look at the slide on top, in this case, again, you have candidiasis, but the central area is raised. There is elevation. So you would describe this as a maculopapular rash with central plaque formation. Vesicle and bulla, I think everyone's already very familiar with those terms. You know that a vesicular rash is a rash that's characterized by blister formation. Vesicles are small blisters. Bulla are large blisters. Those are terms that we already use pretty accurately. Pustule, again, I think we're very familiar with this. This is a papule that is filled with purulent fluid. A pimple or a zit is one example of a pustule. But in this case, you see that this patient has a peristomal pathology that's characterized by pustular lesions as well as generalized erythema and induration. So anytime you see little elevated lesions, less than 1 centimeter in diameter, filled with purulent fluid, you refer to those as pustules or a pustular rash. Abscess, we don't typically use that term because abscess is actually diagnosed either through imaging studies or through incision and drainage. What we would usually document would be superficial erythema and induration, but as a wound care nurse, I can't say that a patient has an abscess because that's not within my scope of practice to diagnose. Now, the next two terms we use extensively, denuded and denudation. Denudation refers to loss of the superficial layers of the skin. And when you say that there's extensive denudation, that means that there's extensive skin loss in that area. If you say patchy denudation, Obviously, it tells you there's little patches where the skin is lost. One thing I should clarify about the term denuded and denudation, it really replaces the term excoriated and excoriation. As nurses, most of us have used the terms excoriated and excoriation to refer to superficial breakdown. That's not technically accurate, even though we all tend to use the terms exactly the same. Technically, excoriated and excoriation refers to linear scratches in the skin. So if I say the patient has perineal excoriation, then I'm essentially saying that patient scratched himself or scratched herself and created linear breaks in the skin. So you want to think, if you're trying to convey superficial skin loss, denuded is the adjective, denudation is the noun. And then, of course, erythema and erythematous you're already very familiar with and just means red. So if you're really short of time, you can say that the patient has an area of redness or that the area is red. If you have a little bit more time and you want to sound a little more official, you say that the area is erythematous. Now we're going to look at secondary lesions. These are lesions that occur secondary to primary pathology. And again, a lot of these will be very familiar to you. I'm going to emphasize the ones that are particularly important to us as wound care nurses. Now, in this slide, you see both scaling and crusting. Scaling just refers to loose fragments of the stratum corneum, very much like fish scales. And it looks like that. It looks like loose fragments of skin. If you're a picker and you see someone who has a lot of scales on the surface of the skin, it probably makes you want to scoop those scales off. Crust is very different. Crust means dried exudate on the surface of the wound. Crust is the accurate term. Scab is commonly used, but is not a medical term, not a dermatologic term. So it's better to say that the patient has a superficial wound with extensive crust formation. Now, erosion and ulcer, we don't use erosion very often because we're much more likely to use the term denuded or denudation. Ulcer, of course, typically refers to a break in the skin that extends at least to the dermal or the subcu layer. So it implies that there's some depth involved. But, of course, you know that our pressure ulcer staging system also uses the term ulcer to refer to stage 1 and SDTI lesions. So ulcer can refer to an open wound that has depth and extends at least to the subcu, but can also be used to refer to pre-ulcerative lesions such as stage 1 and suspected deep tissue injury. Hyperpigmentation, oops, I'm sorry, let me go back. I don't know what I did with hyperpigmentation, so I'll just talk about it for a minute. Hyperpigmentation and hypopigmentation. Hyperpigmentation obviously means that there's excessive pigment deposits. We see that sometimes in patients with radiodermatitis. We see it also sometimes in patients who have venous ulcers, and they develop that gray-brown hyperpigmentation around the ulcer. Hypopigmentation we don't see as often, but when we talk about wounds that are healing by scar formation, we'll talk about the fact that when the scar forms and then it resurfaces on top, that covering skin can be either hyperpigmented and darker than the surrounding skin, or hypopigmented and lighter than the surrounding skin. Okay. Fissure. I think I missed fissure. Fissure is a linear crack in the skin. Typically, these lesions occur at the base of a skin fold, like underneath the pannus, underneath the breast, occasionally in groin folds. When you see a fissure, you know that that lesion was caused by a combination of moisture and friction. And when we get into talking about superficial versus deep breakdown, we'll talk about a condition called ITD, intertriginous dermatitis. ITD refers to these linear cracks in the skin that occur because the skin is overhydrated. When the skin is overhydrated, minor traction, just separating the buttocks to provide hygienic care, lifting the pannus, lifting the breast, can cause a spontaneous crack in the skin. And then many times frictional forces make that initial break in the skin even worse. It continues to develop depth and may become longer. So when you see a fissure, a couple of really important points. Number one, you don't label it a pressure ulcer. It's a linear crack in the skin. And when you see a linear crack in the skin, you already know that the pathology underlying that break is different. It does not match the underlying bone. It is not a full thickness lesion when it begins. It always starts as just a superficial crack. That tells you a lot. It tells you it's due to moisture and friction. So we spend a lot of time on fissure because it's very important. We're actually going to come back to that. Well, there's the hyperpigmentation that I missed earlier that I was talking about. So there you see it with venous ulceration on top and with radiodermatitis on bottom. And then the last several terms relate specifically to open wounds. Granulation, eschar and slough, tunneling or sinus tract formation, and undermining. These are terms you will use every single day in your documentation if you're providing wound care. So you want to make sure you're using them correctly. Now, granulation tissue, you're all familiar with that term and with that concept. But I want to clarify what granulation tissue is. What constitutes granulation tissue? Granulation tissue is newly formed connective tissue proteins in conjunction with newly formed capillary loops. And it's that combination of new collagen fibers and other connective tissue protein strands and the capillary loops that give granulation tissue its dark pink or bright red color and that irregular, bumpy, very tight surface. Granulation tissue is not smooth. Granulation tissue is always irregular. It's always very light on the surface, and that's because of those capillary loops. So if you say that a wound is granulating, you're saying two things. You're saying that when you look at the base of the wound, you see that bright red, irregular tissue. And secondly, you're saying that the wound is healing. So you want to make sure that if you say the wound is granulating, it really is. Slough and eschar, two types of avascular tissue. Whenever you see tissue that is brown, black, gray, that tissue is typically labeled eschar. Most of the time you start out with eschar that's very dry and desiccated, and then as you work to rehydrate that wound surface and to begin the debridement process, then many times that dry brown, dry black tissue becomes softer, but the color remains the same. Brown, black, gray is typically referred to as eschar. In contrast, avascular tissue that is yellow-white, or may sometimes have a little bit of green to it, is labeled slough. Slough looks very much like chicken fat. So when you think about taking a chicken breast and pulling off the skin and seeing those little blobs of fat, that's exactly what slough looks like. Very soft, globular, yellow-white, typically represents dead fat. I will mention that some people also use the term slough to refer to that thin layer of adherent yellow tissue that can occur on the surface of a wound that's very heavily colonized. Most people use the term biofilm or fibrinous film to refer to that thin layer of adherent yellow tissue that can just be scooped off the wound. But you will occasionally see an author refer to that as slough as well. I differentiate because it's very different than this yellow-white globular tissue that you find in a pressure ulcer. When you find yellow-white globular tissue in a pressure ulcer, you're looking at dead fat. That yellow tissue developed because of ischemia. In contrast, when you have a recurrent yellow film on the surface of, say, a venous ulcer, that is not caused by ischemia because venous ulcers are not ischemic. That is caused by bacterial growth and bacterial activity. So actually 2 pathways to yellow tissue, an ischemic pathway and an infectious pathway. You can use the term slough to refer to either because it has not yet been clearly defined. But most commonly, people use the term slough to refer to avascular or dead fat. So here you see a lot of slough, and in both of these wounds you have an ischemic process. Both of these wounds were pressure ulcers. And you can see that this is loose globular tissue, that it represents fat that is necrotic, and obviously that has to be removed. Now the last 2 terms, tunneling and sinus tract, and then undermining. These 2 terms help you to capture any tissue damage that extends out from the edge of the wound underneath the intact skin layers. Tunneling or sinus tract formation is used to refer to tissue damage that extends in one narrow plane, just one direction. So you might say that this wound exhibits tunneling at 12 o'clock, extending 3 centimeters. And that tells me, if I'm doing follow-up on that wound, that I need to take my cotton-tipped applicator or my metal probe or my little suction catheter, and I need to carefully explore right at 12 o'clock and see how extensive that tunnel is on my follow-up visit. It also tells me, when you say it's at 12 o'clock, it tells me it's a very narrow path of additional tissue destruction. It doesn't extend from 11 to 2 or 12 to 3. It's confined to that one plane, 12 o'clock. In contrast, undermining, which we see here, is additional tissue damage that extends out underneath the edge of the wound, and it continues for some distance. So typically we will say there's undermining from 2 o'clock to 5 o'clock, extending 3 to 4 centimeters. If you look at the wound on bottom, that's probably easier to see the orientation because the patient's head's right here, feet here. So you can clearly see that you've got undermining that extends from about 12 o'clock all the way over to about 5 o'clock. And then you would have to use your probe to determine how far that undermining extended in terms of distance from the wound edge. So if you have a very narrow path of additional tissue destruction, you usually label that either a tunnel or a sinus tract. Those terms are used interchangeably. If you have breakdown that follows the contours of the wound, extends out underneath the wound edge but goes for a distance, that's undermining. One other thing I want to mention in relation to terminology is you want to make sure that as the wound care nurse, you are always using correct anatomic designations. Very common to pick up a chart and see where people have documented that there's breakdown on the hip or there's breakdown on the buttock, and you're not really sure exactly where it is. If it's a pressure ulcer, the correct terminology to designate that pressure ulcer is the underlying bony prominence. And I just want to point out a few things. So if you're saying it's coccyx, you mean the base of the spine. But many times coccygeal wounds also extend up and involve the sacrum, so many times we end up using the term sacrococcygeal. If it's an ulcer that occurs on the sitting surface and a patient is in the wheelchair a lot or at the bedside a lot, that's over the ischial tuberosities. Of course, you're familiar with trochanters, okay? Now, another area that you want to be really clear about is what you call this. And I know we call it the crack, but what you call it on the chart. And the accurate term is natal cleft or intergluteal cleft. The gluteal fold is actually this. It's the fold between the buttock and the upper thigh. So make sure that you're using correct anatomic terminology. If you're not sure, look it up. Teach your staff to use correct anatomic terminology so that the person who picks up that record can tell where that wound is. Okay, now come over to the section in your module that's entitled Overview, Skin Breakdown, Problem, and Issues. I want to go over several things here. Now, when you look at your blueprint for your exam, you'll see that this is not on your blueprint, and that's correct because the intent of this section is to give you an overview and to alert you to some of the issues that you're going to encounter as you study more about wound care and as you become the expert in wound care. Lots of issues related to terminology. So you know that in the past we called pressure ulcers decubitus ulcers. And you probably also know that that's no longer accepted terminology. The reason they used the term decubitus was because it meant lying down in Latin. And because most people who developed breakdown were bedbound and lying down. But of course it does not describe the pathology. So that explains the transition from decubitus ulcer to pressure ulcer. When you say that patient has a pressure ulcer, you are defining the pathology of that wound. And the pathology of pressure ulcer development involves soft tissue compression, vessel compression, tissue death. All of our current data indicate that pressure ulcers begin deep. They begin at the muscle-bone interface and they come up. So that tells you that if you label a wound as a pressure ulcer, number one, you've got to look at location. It should either be over a bony prominence or under a medical device where there's tissue compression. It tells you that almost always those wounds will be deeper wounds that typically extend to the fat or the muscle. And it also tells you that that wound will exhibit signs of tissue ischemia, tissue death, that you're very likely to see slough or eschar or a crater where tissue has been lost. So that's what a pressure ulcer really is based on what we currently know. But look at all of the wounds that are frequently labeled pressure ulcer. In some agencies, almost anything in the trunk area is labeled a pressure ulcer, even though many of those wounds are actually due to friction from the patient shifting around in bed, or they're due to exposure to stool and urine like incontinence-associated dermatitis, or they're due to trapped moisture at the base of a body fold and then minor friction or minor traction that causes a fissure, that longitudinal lesion. Current terminology for that, intertriginous dermatitis. What I want you to realize is that what you call wounds matters. First of all, it matters because the way you label a wound should designate the pathology. And in designating the pathology, you also lay the groundwork or the pathway for preventive care and appropriate interventions. But also look at the 3 factors that are listed on your handout as to why it's very important to make sure that you are not calling a friction injury a pressure ulcer, that you're not labeling intertriginous dermatitis a pressure ulcer, okay? In addition to the fact that it leads you down the wrong pathway in terms of prevention and management, think about the impact in terms of regulatory issues and litigation. In our current world, agencies are sometimes fined for nosocomial pressure ulcer development. It impacts on payment, and it significantly impacts on their risk of litigation. So you definitely do not want to be labeling things as pressure ulcers unless they're caused by tissue compression and loss of blood flow. Also think about the fact that in 2012 you're expected to benchmark. So we're all running around doing prevalence and incidence studies. We're going to talk more about that in just a minute. And then we compare our prevalence and incidence data to other agencies of comparable size, comparable patient population. And we look to see, are our numbers the same? Are they better? Are they worse? But think about the impact if in my agency, everything that occurs in the trunk area is labeled pressure ulcer. So it might really be friction, but it's over the buttocks, so I call it a pressure ulcer. Maybe it's really intertriginous dermatitis occurring in the natal cleft, but it's in the trunk. I just label it a pressure ulcer. Label it a pressure ulcer. Incontinence-associated dermatitis, frequently labeled pressure ulcers. So if in my agency everything is classified as a pressure ulcer, but in the agency across town they're very selective. And they do not use the designation pressure ulcer unless it meets the criteria of being over a bony prominence or under a medical device, of exhibiting some degree of tissue ischemia and tissue loss, and probably being a full thickness wound. You can see that my numbers are going to be much higher than the other agency's numbers. And it means that benchmarking is irrelevant, is of no value. So many reasons for us to get it right. If we get it right, we follow the right path for prevention and management. If we get it right, then we do not set ourselves up for regulatory fines and litigation in situations when we're not at fault. And if we get it right, our benchmarking is of value. So we'll come back to that in the next section. We'll actually be talking about superficial damage, deep damage, what are the characteristics of moisture-related lesions, what are the characteristics of pressure and shear damage. Now I put some slides up here just to really illustrate that you can have a variety of wounds in the trunk area. They can all be caused by different etiologies. For example, this patient had incontinence-associated dermatitis. The skin was overhydrated because of constant exposure to liquid stool. They had been using zinc oxide over the buttocks, and when they cleaned the patient up aggressively, they took off skin. If you look at the patient on top, this was friction damage. The patient, you can see, is very, very malnourished, has very, very thin skin, and was shifting around in bed, restless, and literally just peeled skin off. Friction damage, very superficial, no evidence of ischemia. You see no evidence of ischemia. There's no evidence of tissue loss except for the very top layer, and the base of the wound looks bright red, so there doesn't appear to be any ischemic process going on. But think about how many times both of these patients would be classified as having stage 2 pressure ulcers. Top right, we talked about this already. This is a moisture-related lesion. This is a linear break in the skin, a fissure. That would be correctly classified as intertriginous dermatitis. We'll come back to that. And then the one pressure ulcer is the one on the bottom right. And of course, it's over the right trochanter. The contours of the wound reflect the contours of the underlying bony prominence. You clearly have significant tissue loss and slough in the wound bed. Now this is just a quick overview of our approach to wound care. This is the way we teach it. This is the way we practice it. So you're going to hear this and see this over and over. And we sometimes call this the ESP+E approach to wound management. And what we're referring to is the 4 elements that are absolutely critical to effective evidence-based wound care. E, identify the etiology of the wound and do everything you can to correct the etiology factors. You have to interrupt the cycle of injury. S stands for systemic factors. I know you have probably all told a patient and his or her family that wounds have to heal from the inside out, and that's exactly right. We don't heal the wound. The body heals the wound. It's the fibroblasts that make the new collagen and other connective tissue proteins. It's the endothelial cells that generate new capillaries. It's all done by the cells in the body. And what we know is that those cells work best when there's adequate blood flow and adequate oxygenation. They work best when glucose levels are tightly controlled. They require key nutrients to be able to make new tissues and to fill in the gaps left by that wound. They are compromised by high doses of steroids. So all of these things make a difference, and we have to pay attention to systemic factors. We have to pay attention to perfusion, to nutrition, to medications, to glycemic control. We'll come back to that. P stands for principle-based topical therapy. We know so much more about how wounds heal. We know so much more about what kind of local environment supports wound healing. We have so many advanced wound dressings available to us. When we talk about principle-based topical therapy, we mean that you are appropriately matching the dressings and the topical products to the wound characteristics. For example, you know that if you have a wound with large volumes of exudate, you've got to select a dressing that will effectively manage that exudate so that you don't end up with large volumes of fluid sitting in the wound bed. We also know that it's critical to keep the wound surface itself moist so the cells don't die and so they can migrate. So you've always got to manage your exudate. You've always got to maintain a moist surface. If that wound is located in the perineal area and the patient's incontinent of stool, clearly you need a bacterial barrier so that bacteria cannot penetrate the wound bed. So you would need a waterproof cover dressing. Very simple concepts. So when we talk about principle-based topical therapy, we mean that you carefully assess the wound, and then you look at the products you have available and you create a good match. Wet wounds get absorptive dressings. Dry wounds get hydrating dressings. Wounds exposed to contaminants get waterproof cover dressings. We're going to go over that in detail. And then the last plank is the second E, and that is follow-up evaluation. We always do this for any care plan we put into place. We monitor to see, is it working? Is the wound getting better? Has the wound plateaued? Is the wound deteriorating? So throughout this course, we're going to talk about assessing the wound to determine etiologic factors and then strategies to address those. We're going to talk about the systemic factors that are important in wound healing and how to control those. We're going to talk about all of the products that are available and their unique characteristics and how you match the product available to you, the products available to you, to the wounds that you're caring for. And then what do you look for when you're doing follow-up assessment? What are your indicators that the wound is in trouble? When do you go back to the drawing board and reevaluate? So we'll come back to all of those. Okay, now we're going to talk about prevalence and incidence studies. This is going to be an important responsibility for all of you in inpatient settings like acute care, long-term acute care, long-term care. It will also be of significance to those of you in home health, not of significance to those of you in outpatient care. So let's first look at definitions. Prevalence means the percentage of patients who have a condition at a certain point in time. So if you make walking rounds, you involve 100 patients in your agency, and 10 of those patients have breakdown, that tells you that at that point in time, you've got 10% prevalence. Prevalence alone does not tell you anything about your preventive care. Incidence tells you about preventive care, because incidence captures the percentage of patients who develop a problem during a certain period of time, like after admission. Now, you'll see on the slide, and you'll see this in the literature, that there's a new term out there, and they talk about prevalence of hospital-acquired pressure ulcers. And that essentially is a synonym for incidence. Now, how would I get that data? Well, let's say that I went back, same 100 patients, we surveyed those 100 patients. 10 patients had breakdown, 10% prevalence. I go back and I look at the nursing admission for those 10 patients who have breakdown at this point in time. And I find that 5 of those patients had breakdown at the time of admission. Those were not hospital acquired. But the other 5 were admitted with intact skin. Our nursing admission notes say skin intact, no breakdown. Those 5 patients developed breakdown after admission. Those are hospital acquired. That would give us a 5% hospital acquired pressure ulcer prevalence rate. Same thing as 5% incidence rate. So incidence, very important when you're looking at the efficacy of your prevention program. How do you measure the efficacy of your prevention program? You look at incidence of hospital-acquired pressure ulcers, or you can look at prevalence of hospital-acquired pressure ulcers. Either way, you're looking at the same thing. What you want to know is what percentage of patients develop breakdown after admission. Now, this is going to be something that we talk about at more than one point during the course, because for those of you who are going back to hospitals, long-term acute care facilities, long-term care facilities, one of your responsibilities will be to establish an agency-wide program for pressure ulcer prevention and to monitor the effectiveness of your prevention program. And the only way to monitor the effectiveness of your prevention program is to track incidence, to determine how many patients are developing breakdown after they're admitted to your agency. So that's why we keep focusing on incidence or hospital-acquired pressure ulcers. So whether you talk incidence or you talk hospital-acquired, you're talking the same thing. Now I wanted to just go over some approaches to doing prevalence and incidence studies. One is what we just talked about. You make rounds, you develop several survey teams. Let's say you have to survey 300 patients. Well, you're going to need a minimum of 6 to 10 survey teams. Each survey team is 2 people because they've got to go to the bedside, they've got to inspect that patient's bony prominences, they've got to record any areas of actual breakdown and impending breakdown. If a patient shows evidence of impending breakdown, they have to go back 30 to 45 minutes later so that they don't confuse a normal condition, reactive hyperemia, with an abnormal condition, stage 1 pressure ulcer. So it's very time consuming. Then they're going to have to go back on any patients who do show evidence of breakdown. They've got to go back to the nursing admission notes to see did that patient have breakdown on admission. But that's one approach to capturing prevalence and incidence data. It will tell you overall the percentage of patients who have breakdown at that point in time. But the more critical information is the percentage that were hospital acquired. Okay, another approach, and a lot of you have been involved in this because some of your bed companies help with this approach. And that is, we're going to take our same 300 patients. And let's say that you do your prevalence study on March 15th. And so you survey all 300 patients and you find that, say, 30 have breakdown. So that gives you, again, a 10% prevalence. But in this case, instead of looking back to determine how many of those were hospital acquired, you simply capture prevalence at this point in time. You go to medical records and you ask them, what's our average length of stay? And they say our average length of stay is 6 days. This is March 15th. You count forward 6 days, and on March 20th, or excuse me, March 21st, can't count, On March 21st, you do a follow-up survey. The only patients who are included in the survey on March 21st are patients who were in the hospital on March 15th, who are still in the hospital on March 21st, who had no breakdown at the time of the initial survey. So let's go back. Initial survey, you looked at 300 patients. 30 of those patients already had breakdown at that point in time. You will not go back and resurvey those. That leaves you 270. Let's say 150 of those patients were discharged between the 15th and the 21st. That leaves you 120 patients to survey. So if you go and you survey those 120 patients, and 6 of them had developed breakdown, that would give you a 5% incidence rate. So when agencies talk about doing a prevalence and incidence study, that's usually what they're talking about. A prevalence study followed by an incidence study, typically 5 to 7 days later, usually at an interval that represents average length of stay. Now, this type of survey gives you very helpful data in that it gives you overall prevalence and then it follows it up with incidence. But it's very time consuming, takes a lot of resources. And it gives you just snapshot in time. It doesn't give you data over time. Now, a lot of agencies who are pursuing magnet status are doing quarterly incident studies. And typically when they do the quarterly incident studies, they do that one-time survey and then they look back to see which of those ulcers develop following admission. Okay. Now the last thing I want to talk about is the trend. And the trend is to do ongoing monitoring and then to do something called root cause analysis. Now before we go to this, I just want to back up and make one thing clear. If you're a magnet hospital or if you are pursuing magnet status, at this point in time you are required to do quarterly incident studies, prevalence incident studies. So you're going to do those 4 times a year. You're going to mobilize your teams and you're going to make the rounds and you're going to identify patients who have evidence of breakdown at the time of your survey. For everyone who has evidence of breakdown, you're going to go back to the admission note to see was that breakdown present on admission or does this represent a hospital-acquired pressure ulcer? And that's the data that you will report to ND and QI, National Database of Nursing Quality Indicators. That's valid data. It certainly tells you something about what's going on in your agency. But as the wound care specialist, as the person who's really responsible for driving preventive care throughout your agency, you don't want to stop there. You also want to gather data on an ongoing basis, and you want to gather it in a way that allows you to determine, was this ulcer avoidable? Was it unavoidable? What could we have done differently, if anything? And that's what I want to talk about now. So the last thing you see is this trend to do ongoing monitoring with root cause analysis. Now, how do you do this? There's actually a form that you have online, and if you have the hard copy module, it's in the hard copy module. And the hard copy module is on page 23, and then the root cause analysis form is on page 24. Of course, with subsequent editions, our page numbers change a little bit, but you can look in the index or in the table of contents to see where that form is. What you do is you have to enlist the entire nursing staff. You have to make prompt reporting of any possible pressure ulcer non-punitive. You've all got to be on the same page. It's like we have to be a team. You have to be able to say to your nursing staff, one of the most important things is to catch a pressure ulcer really early. The earlier we catch it, the more likely we can intervene to prevent any significant tissue damage. Also, every time a patient develops what we think is a pressure ulcer, it gives us an opportunity to go back, look back, and see, is there anything we could have done any better, so that we can constantly improve our care and constantly improve our outcomes. So you get everyone on board. Okay, so let's say that I'm the wound care nurse. I have my little spreadsheets, probably on my computer. It could be hard copy, but probably electronic. I get a call from 3 South. I'm not sure, but this patient has an area between the buttocks, and I think it might be a pressure ulcer. So I go, I look, and I'm like, you know, this is not a pressure ulcer. This is actually intertriginous dermatitis, but I'm really glad you caught it so early. Let's get right on to a management plan so it doesn't get any worse. That patient probably does not go on your spreadsheet because that patient does not have a pressure ulcer. Later that day, you get a call from 4 West. Can you come and check this patient? He's got an area on the sacrococcygeal surface that I think might be a pressure ulcer. You go, it is a pressure ulcer. It's a suspected deep tissue injury. Okay, now you're going to enter that patient on your spreadsheet. You're going to enter whatever you determine to be critical information. It's usually medical record number, gender, age, unit that the patient is on, site, anatomical site of the pressure ulcer, stage of the pressure ulcer. Okay, that's critical basic information. And you can see how just that information allows you to do a lot of problem solving. What if I look back at the end of the month and I'm like, well, we had 10 new pressure ulcers this month. All of them were stage 1 or SDTI. None of them were open wounds. Okay, that part's good. But 8 of 10 occurred in the orthopedic unit, and they were all heel ulcers. Well, think how important that data is to you. That gives you very different data than you might get when you do your one-time survey 4 times a year. Because now you're like, wow, something's going on in the orthopedic unit. Specifically, we're not doing a good job with heel elevation. It allows you to intervene in a much more meaningful way. So think about tracking data on an ongoing basis. And even more importantly, think about doing root cause analysis. Now, if you look in your table of contents, you'll see that you have a root cause analysis form. It's also attached onto your blackboard, and I want you to just look at that. I want to go over that for just a minute. Doing root cause analysis is probably one of the most important functions that you can undertake as a wound care nurse for your agency, because it is the best way to determine if you're doing everything that needs to be done to prevent pressure ulcers, or if there are ways you can improve. Agencies who have initiated root cause analysis have been able to significantly reduce their incidence rates by information that they gained. For example, back to that orthopedic unit. It's like, well, let's make sure that heel elevation is the standard of care. What's interfering with heel elevation? Oh, well, you know, we don't have them on the unit. We always have to remember to go back and order them, and then there's a lag time between when we order them and when they come up, and sometimes they don't send both of them, they only send one. Okay. Lots of ways you can intervene to improve care. And one of the agencies I was involved with, we found that we were developing a lot of heel ulcers in our cardiovascular surgical ICU. So we asked the staff about their routine for heel elevation. And they're like, well, you know, we don't routinely put everybody in boots because they're expensive. Those boots are expensive. So we're thinking, yes, well, so are pressure ulcers. But we're like, okay, so how do you decide who gets a boot? Well, if we don't discharge them from cardiovascular ICU in 48 hours, if they're not mobilizing at that point, then we put them in a boot. Well, what do you already know? It's too late. So when we looked at the data, then everybody involved in quality improvement for that unit's like, oh, we've got to put everybody in a boot because we can't predict who's going to get into trouble. waiting until they get into trouble means that we have a serious ulcer that we could have prevented. So it changed their preventive care. Another group found that their total hips were their high-risk population. Those were the patients who kept breaking down. How did they find that out? By doing this tracking and then going back and looking at root cause analysis, and what they realized was the staff did recognize that these patients were high risk and that they needed to go on a higher level surface. But by the time they got that surface ordered, well, let me back up. When did the staff recognize this? After the patient had left the operating room, gone to PACU, come into the unit, been assessed, then they were classified as high risk, then they initiated the process for ordering a higher level support surface. But altogether, there was a lag time of at least 12 to 24 hours before the patient actually got moved to the higher level surface. So they changed their protocol. And they incorporated transition from the OR table to the high level surface for all their total hips. And what do you think happened to the incidence? Dropped way down. So that's why we really encourage you to do this root cause analysis. You see that it just has you go back and determine what preventive care was done. There's certain questions you answer for a trunk wound, certain questions you answer for ulcer under a medical device, certain questions you answer for a heel ulcer. We have to realize there are contributing factors. You want to capture those. And then it requires you at the end of the form, after you've gathered the data, as the wound care nurse, it asks you, was this ulcer avoidable or was it unavoidable? Very important, because when you're gathering this information, when you're doing this detective work, if you find that there are significant numbers of avoidable ulcers, then your next step is to put into place preventive programs, corrective programs, to drop the number or to eliminate avoidable ulcers. Okay, so other things I wanted to cover under incidence studies, prevalence and incidence studies. There's issues regarding reporting in Europe. Many agencies report two sets of numbers. They report their overall prevalence and incidence rates, and then they report prevalence and incidence of stage 2 through 4 in SDTI lesions. They omit stage 1. Now, in the U.S., the standard is you capture stage 1, and when you think about the fact that stage 1 represents your window for intervention and prevention, it represents your best opportunity for preventing actual tissue loss. You don't want to minimize the significance of the stage 1 lesion. You don't want your staff to think, oh, it's only a stage 1, no worries. No, it's a stage 1. This is our chance to intervene. So in the States, the standard is capture stage 1, but I just wanted to bring that up. There's a trend to report pressure ulcers in terms of number of patients developing ulcers per 1,000 hospital days, as opposed to reporting percentage. So let me explain to you how that would work. Let's say I'm going to go back to my 300-bed hospital. And if I was doing it based on percentage and I had 20 patients who developed breakdown, that would give me a 15% incidence. Okay? Is that right? That's not right. That's probably not right. Let's do something that's easier for me with math. Okay, we have a 300-bed hospital. We have 30 patients who develop breakdown, 10% incidence. Okay. If you were going to report based on number of new ulcers per 1,000 hospital days, what you would have to do is you would have to go to medical records. You would have to say, okay, I'm reporting for the month of June. There are 30 days in June. What was our average census for the month of June? Our average census was 250. Okay, you're going to multiply 250 by 30. And that gives you your total hospital days for June. And then you can calculate the number of ulcers per 1,000 hospital days. Now, obviously, the math is more challenging. Why would we go there? Because it is a much more accurate way to look at incidents. Agencies who have primarily very short stay patients, when they look at percentages, they're going to look better than agencies who have long stay patients, who have higher risk patients. But if you do it per 1,000 hospital days, everything evens out. So that is a trend. You may see your agency transitioning to that. I'm just mentioning it. It's not right or wrong. It's two approaches. Percent versus number of patients developing new ulcers per 1,000 hospital days. Aren't you glad you don't have to know this for the test, that we're just going over this? Now, the other thing is to think about how you're going to educate your survey teams when you're doing the rounding surveys where people actually go to the bedside, inspect the patient, record the data. And you want to think, what is it that you want your teams to capture? And what data do you want gathered by your wound care nurse, maybe your skin and wound care champions? So in most agencies, what they educate the teams to do is to accurately differentiate between normal and abnormal. You have to educate them in the difference between reactive hyperemia, which is that normal warmth and discoloration that occurs when you turn the patient and does not represent pathology, and resolves typically within 30 minutes. Very different than persistent erythema that is there 2 hours after you turn the patient. That represents an inflammatory response. That's a true stage 1. You want to teach them the difference between blanchable and non-blanchable, because what you want them to accurately capture is pathology, problems. So you want them to capture either persistent or non-blanchable erythema. You definitely want to educate them about suspected deep tissue injury. You might teach them to stage, but staging is very difficult. So in many settings, what they do is they have the survey teams basically determine, are there areas of actual or impending breakdown that appear to be pressure related? Yes, no. Look back. Was this breakdown present on admission? Yes, no. So basically they're determining, or they're differentiating between normal and abnormal. And then in many settings, it's the wound care team that goes back and looks at every patient who was screened out and found to have evidence of existing or impending breakdown that was not present on admission. If you do it that way, first of all, it makes it simpler for the teams. It makes it simpler for you to orient the teams. It also protects the validity of your data, because then you have a very small group with high-level education actually verifying that this is a pressure-related injury and that it is a stage 3 or a stage 4 or SDTI or whatever. So just think about how you will be utilized, what it is that you want your survey teams to do. And we talked about ongoing monitoring and how important that was. And then the last few things that I wanted to mention that we will keep coming back to, but again, this is kind of like an overview session. And that is economic issues. We know that skin breakdown is very costly. Hospitals, long-term care settings, home care settings, every setting is now motivated and incentivized to prevent pressure ulcer formation among their patients. This is tremendously helpful to us because now we have everyone on board. No one wants to see unacceptable pressure ulcer incidence rates in their agency. Everyone wants their rates to be below the national average, and they want to be able to prove that any ulcers that develop are unavoidable. So that's actually been positive. The new focus on non-payment for agency-acquired pressure ulcers has actually been beneficial in that it's increased the emphasis on preventive care. That will help you. We do not have truly accurate data about the cost of pressure ulcers because pressure ulcers have been lumped into one big bucket. We haven't really separated out, well, what's the cost of care for a stage 4, what's the cost of care for a stage 3 for SDTI. But we know it's very costly. That's helping us now. Legal and ethical issues. You know that agency-acquired pressure ulcers are a very common reason for malpractice lawsuits. I believe it's the second most common reason for a malpractice lawsuit. So you've probably heard legal groups advertising. You might have seen advertisements on TV. It tells us that we're being held accountable, which is a good thing. But several things that you want to think about as the leader of the wound care team. First of all, the most important thing is what we've already talked about. You want to mobilize your staff, you want to educate your staff, you want to motivate your staff and incentivize your staff to focus on prevention. If we can prevent pressure ulcers, then we don't have to manage them. When you have a critically ill patient in ICU and that patient finally stabilizes and moves out of ICU and that patient never developed a pressure ulcer, you want to celebrate it. You want to acknowledge it. When that unit drops their incidence rate significantly, you want to acknowledge it. So your number one priority as the wound care nurse for your agency is to focus on prevention. Be the cheerleader for prevention, okay? That's the biggest thing. But there's some other things to think about. You'll also be responsible for developing or reviewing and revising all of your policies and procedures related to pressure ulcer prevention and wound management. And you want to make sure that your policies and procedures don't put you in a difficult position. I'm going to give you an example that I think will make this clear. Many agencies have prevention protocols that say turn Q2 hours, period. Very black and white. Now, if you go to the literature, you will find studies that show that patients who are managed on good quality support surfaces like 4-inch foam mattresses or 8-inch foam mattresses, I think, can be repositioned every 3 to 4 hours with no increase in the incidence of pressure ulcer development as compared to patients repositioned every 1 to 2 hours. We know this makes sense, doesn't it? All of the Q2 hour protocols were developed when we did not have pressure redistribution mattresses. All we had was the standard hospital mattress. Now we have a wide variety of very effective pressure redistribution surfaces. And what these studies are showing, we only have a few, we need more, but what these studies indicate is that if you have that patient on a good quality pressure redistribution surface, you can reposition them less frequently and still protect them. So maybe I have this patient on a high-level air mattress with a low shear, low friction surface and low volume airflow, and I'm turning that patient every 3 to 4 hours. Usually every 3, occasionally it's every 4. But if that patient develops breakdown and that case goes to court and the attorneys are reviewing the notes and they find that that patient was turned every 3 to 4 hours when your protocol said every 2, then you're in violation of your own protocol. You have violated your own standard of care. So my point is, you're the one that will be reviewing the policies and procedures. Make sure they're written from a clinically appropriate perspective. So it would be much better to have your policy and procedure, your protocol, say something like, reposition Q2 to 4 hours based on skin status, patient tolerance, and type of support surface. That avoids boxing the staff into a little corner. So just think about that. What else did I want to tell you about legal issues? I think those were the main things. I do have one other thing I wanted to mention about legal issues, is that staff will frequently come back and say, well, I didn't turn that patient from 10 p.m. to 6 a.m. because he was hemodynamically unstable. But you can't come back after the fact. You have to document it at that point in time. It is okay to document with one line, so you don't have to document every single time, but at the end of the shift, you should say, unable to reposition from this point to this point due to hemodynamic instability. Or if the patient refuses repositioning at 3 out of 4 times during your shift, even though you educated the patient, reinforced the importance of turning, you need that one-line note. Patient refused turning 3 out of 4 times on this shift, despite education and counseling. And finally, what about charting by exception? That is not acceptable. It's not okay to say, well, we turn everybody who's on prevention protocols. We always turn people. And there's no documentation of turning and positioning. You've got to have documentation. It can be a flow sheet. It can be documentation at the end of a shift that the patient was turned Q2 hours during this 12-hour shift. You can't do it at the beginning of the shift, obviously. It has to be the end of the shift. But somehow you have to capture that that patient did receive appropriate preventive care. Otherwise, if that case comes to court, you'll have no protection, and you'll look as if that ulcer was your fault. The next thing I want to mention is ethical issues in caring for terminally ill patients. We know that they're extremely high risk. We also know that many times the patient and the family make a decision that comfort's a higher priority than anything else. And you know what? Most of the time we would totally agree with them. But it's important to document that in the record, because if that case did come to court, if there was a lawsuit and there's no documentation that the decision had been made in conjunction with the patient and family to focus on comfort, to turn that patient much less frequently, even though it increased the risk of skin breakdown, how are you going to prove that? So you want to talk with the patient and the family. You want to say, we've conducted a risk assessment. Your mom's very high risk for skin breakdown. You're very high risk for skin breakdown. A critical strategy for preventing skin breakdown is to turn you every 2 hours or every 3 hours. We do have you on an air surface, so we could turn you every 3 hours. But we would need to turn you about that often to give you good protection. I know it's very, very uncomfortable for you when we turn you. Now, here are the things that we're going to do. We're definitely going to keep you on your pain management protocol. You can elect to be turned less often. You can choose when to be turned. But I want you to be clear what that means. It will probably make you a lot more comfortable, and we're willing to do that, but it will also increase the risk that you could develop what people call a bed sore. And I can't make that decision for you. That's your decision. We just need to talk it through and decide what's more important to you, protecting your skin or reducing your pain. And you need to document whatever that decision was. Okay, let's see if there's anything else I wanted to cover. Yes, I wanted to just mention that we are all expected to provide evidence-based care. I know you're all very tuned into that. In terms of pressure ulcer prevention and management, there are 2 sets of guidelines that are current, that are evidence-based. One is from the WOCN Society. You're going to hear a lot about the WOCN Society. When you graduate, they will offer you the opportunity to purchase a WOC Nursing Essentials disc that includes all of their evidence-based guidelines, including the guidelines for pressure ulcer prevention and management. There's also a set of guidelines that were developed and published by the National Pressure Ulcer Advisory Panel and the European Pressure Ulcer Advisory Panel working together. Tremendous overlap between the two sets of guidelines, not surprisingly since they pull from the same set of literature. But those are the two sets of guidelines that you would want to have access to, that you would want to reference. When you're updating your protocols, you want to go to those guidelines. You want to make sure that your protocols are consistent with those guidelines, and you want to list those guidelines as your references, so it's very clear to everyone that your protocols are evidence-based. So to get the NPUAP guidelines, you go to www.npuap.org. To get the WOCN guidelines, www.wocn.org. But don't get them yet. Wait till you graduate, wait till you're a member, you'll get them at a much reduced rate. Okay, thank you very much. We're going to stop there, and then our next session will address causes of breakdown, superficial and deep. Thanks.